Uh, Today we will discuss about epilepsy or seizure from Harrison. In our world, in our outdoor service emergency, we found many seizure patient, epilepsy patient. It may be true seizure or pseudo seizure, and if it is a true or pseudo seizure, we can differentiate from it from history and physical examination. First, we have to exclude: is it a true seizure or it's a pseudo seizure? If it is true seizure, uh, then there will be tongue bite. Patient cannot remember the point of seizure, and there will be history of recurrent seizure. And we have to exclude those things. It is syncope, it is a TIA, transient ischemic attack, migraine, acute psychosis, and other cause of episodic cerebral dysfunction. First, I have to think one thing. You have to ask the patient, is there any history of epilepsy, and is he currently treated for anti-seizure drug? If in epilepsy patient history is from childhood, is suffering from disease from childhood, in new onset disease we have to consider many things. But in a established epileptic patient, we will first think about the adequacy or appropriate dose of the anti-seizure drug therapy. We need to reduce or we need to increase the dose, side effect and serum level. If it's okay, if we do is an adequate dose, it is inadequate, then we have to do, we need to do in further, we need not to go down in further checklist. But if there is no history, then we have to think many things. First, we will exclude the CBC or not, then we will go for CBC. What CBC? Is this, it is ineffective any cause? It is any meningitis or encephalitis or meningoencephalitis? You have to think about electrolyte. Is there any hyponatremia? Is it any hyperkalemia? In hyponatremia, in SIAD, in another things, hyponatremia may cause epilepsy or seizure. In calcium, there is hypercalcemia, hypocalcemia. Mainly hypocalcemia causes seizure or epilepsy. How hypocalcemia causes? Hypocalcemia, it is essential thing for nerve conduction. Why is there is low calcium? There is a neuronal hyperexcitability, and magnesium is the same thing. Magnesium is very essential for calcium's active form. It's maintain the level of calcium. In glucose, we will first think about hypoglycemia. In calcium, in hypercalcemia really cause epilepsy. In hypothyroidism, in hypocalcemia, we have to cause the main cause. We have to think about the cause of the hypocalcemia. We have to think in hypoparathyroidism. We have to check the serum PTH level. In hypothyroidism, the main cause, most of in our country, the thyroid operation or in neck operation, autoimmune cause, idiopathic cause, vitamin D3 deficiency, so on. And in serum glucose level, we have to think in hypoglycemia due to insulinoma, adrenal insufficiency, hyperglycemia may cause the epilepsy. Liver and renal function test. In renal problems, there will be uremia, there will be confusion, there may be cause epilepsy. In hepatic encephalopathy, in chronic liver disease, this cause. In urinalysis for any renal pathology, liver pathology, any drug cause, to explore drug cause, toxicological scene. We think the amphetamine, cocaine, and other drugs many drugs may cause seizure. So we have to think the patient is taking any drugs, any toxin that causing the seizure. In there, if he is already taking epilepsy drug, we if we think the anti-seizure drug is appropriate or adequate is enough, then we have to do same thing again. Calcium, electrolytes, CBC, glucose level is normal, then we will adjust the drug level. It may be suboptimal dose. We may increase another alternative anti-epileptic drugs. It is abnormal, anything abnormal, then this kind of thing we have to exclude. If everything is negative, MRI and EEG is laboratory studies negative, MRI, EEG, focal seizure, focal abnormality, other neurological dysfunction. In metabolic cause or an infection cause, first we have to do is lumbar puncture for exclude any neuroinfection. The endocrine study. With endocrine study, we mentioned before there's any adrenal insufficiency. Is there any hyponatremia? Is there any adrenal cause? CT, MRI, if focal features present. Then, if metabolic cause, underlying abnormality, we have to exclude, and if not, then anti-seizure drug. Idiopathic seizure, if there is any, then go here. If we got MRI, any neurological dysfunction, we have to like muscle lesion, strokes, CNS infection, trauma, renal change, we have to treat the underlying dose. If there is no other cause, idiopathic seizure, consider anti-seizure drug. That's what in Harrison. One thing very is interesting that most of the things are in flowchart, and flowchart is very easy to remember, eye-catching. Thank you. I think you got a good shortcut technique to deal with a seizure patient that we encounter as a doctor.